Hello, and welcome everyone to today's webinar brought to you by No Diabetes by Heart. That's a joint initiative between the American Heart Association and the American Diabetes Association. Welcome to the webinar. I'm Kevin Peterson. I'm the Vice President of Primary Care at the American Diabetes Association, and I'll be moderating today's program. Today, we're joined by 4 experts who will translate the findings from the American Diabetes Association's 83rd scientific sessions that took place just a few short weeks ago. Today's panel presenters include Dr. Vanita Aroda. She's an endocrinologist at Brigham and Women's Hospital. Dr. Mark Benson, a cardiologist at Beth Israel Deaconess Medical Center. Dr. Peter Bjornstad, an endocrinologist at the University of Colorado Anschutz School of Medicine. And Dr. Tracy Taveira, a professor of pharmacy at the University of Rhode Island. We've listed here the faculty disclosures. Before we begin, we'd like to recognize the No Diabetes by Heart founding sponsor, Novo Nordisk. Along with our national sponsor, Bayer, thank you both for your support. Today's session will be recorded. The recording will be available for viewing on the No Diabetes by Heart website. We'd invite you to visit the No Diabetes Heart website, that is nodiabetesbyheart.org, for downloadable patient materials that will support you in your practice. It has guideline information, case studies, and a library of our previous webinars and podcasts. Please stay tuned as we continue to roll out more webinars and other podcasts for healthcare professionals. We'll be hosting a Q&A session at the end of today's presentation. We'll try to address as many questions as possible at the end. Now, let's get started. I'll pass it over to you, Dr. Aroda. Could you review some of the key findings from the 83rd scientific sessions?
Thank you so much, Kevin. It's so great to be here with all of you. There were so many sessions to choose from. The one that I'll start off with was the updates on the standards of care from the American Diabetes Association. Now, as you all know, the American Diabetes Association updates its standards of care every single year. And so that's, come January, that's the go-to place to see what evidence has changed and what the recommendations are. And I was privileged to be a part of the practice committee for the previous 3 years that updated these recommendations. And so I'll start there. The big update is in the algorithm or recommendations for treatment of type 2 diabetes. And the first principle you'll see is that what's really recommended is a holistic approach to the person in the adult with type 2 diabetes. So for the first time, equally important are glycemic management, cardiovascular risk factor management, weight management, and organ protection. So using agents that have been demonstrated to reduce cardiovascular disease and renal outcomes in individuals at risk. So that's the first principle. The second is if you actually look at the algorithm of, okay, what medication do I start with? When do I add second agent, third agent? You know, that was very prescriptive in years previous. In this version, it is very person-centered. So first off, by making sure that everyone has healthy lifestyle enforced throughout the lifespan, social determinants of health are addressed, and everyone has access to diabetes education and self-management support. And then in terms of medication, it really goes back to the person in terms of what the goals are. And so there's 2 key decisions to be made with every clinical encounter. And one is this person at high cardiovascular risk as defined by established atherosclerotic cardiovascular disease, established chronic kidney disease, established heart failure, or high risk of these conditions, where you'd go down the left side of the algorithm of thinking about your organ protective agents, your GLP-1 receptor agonists, and your SGLT2 inhibitors that have been demonstrated to reduce these outcomes in the large trials. And then the right side of the algorithm, which is equally important, is how do we get to goals? So choosing approaches and agents that have the efficacy to support the glycemic goals and understanding that weight management is a part of that and contributes to it. Another big update is in the cardiovascular section, where we talk about cardiovascular risk factor management. And blood pressure goals have been stated based on, again, consensus, as well as review of the literature studies, such as the STEP study, which showed benefit of intensive therapy, where the recommended goals for blood pressure are now less than 130/80, as can be attained safely. Another update is in the lipid management goals. And so this is again in section 10, the cardiovascular section. And what we see there is that for adults with diabetes age 40 to 75 without established atherosclerotic cardiovascular disease, moderate intensity statin is recommended. But if they have additional cardiovascular risk factors or enhanced risks, you would think about also a target LDL. And so considering a target of less than 70. For those who you're treating for secondary prevention, again, a high intensity statin is recommended, and an LDL target of less than 55 and or a reduction of LDL by 50%. So there's much more guidance there based on the updated literature. The last thing I'll comment on is there are significant updates in the technology section and on screening for fatty liver disease or early screening for non-alcoholic fatty liver disease, where FIB4 screening is recommended. And then on the technology front, considering technology early and sustained without disruption, particularly in people with type 1 diabetes or people in type 2 diabetes who are treated with insulin. I'll hand it back to you. Those are some key updates.
Thanks so much, Dr. Aroda. If you could summarize the main takeaway from the session or the main activation for one's practice, what would that be?
I would say taking it back to the bedside, the one thing is consider your full cardiometabolic risk of the person in front of you. And all the cardiometabolic conditions kind of cluster together, whether it's albuminuria, kidney disease, heart failure, or fatty liver disease. And so think about your cardiovascular and cardiometabolic risk stratification and identifying what their long-term risks are. And then second is tailoring your therapies appropriately using organ protective agents as indicated, but never forgetting to get to goal and keep to goal.
Well, that sounds great. And I love the idea of embracing the holistic approach. It's important. Dr. Benson, I'm going to turn it over to you, Dr. Benson.
Oh, thanks. I was just saying thanks, Kevin, and it really is a pleasure to be here. I actually wanted to highlight a late-breaking poster that was simultaneously published actually in JAMA. And what the poster addressed was the use of bempedoic acid for primary prevention of cardiovascular events, specifically in statin-intolerant patients. And this was presented by Dr. Stephen Nissen, who, of course, is the medical director of the Cleveland Clinic Coordinating Center for Clinical Research on behalf of the CLEAR investigators and patients. And this was a study that was sponsored by Aspirion Therapeutics, which makes bempedoic acid. Really what the study set out to ask, to address was the question in primary prevention patients who are at high cardiovascular risk and who are not able to tolerate statins, does bempedoic acid reduce major adverse cardiovascular events? And so, bempedoic acid, as we are all growing more familiar with, is this intriguing compound that's an ATP citrate lyase inhibitor. And it targets cholesterol synthesis right upstream of HMG-CoA reductase, which of course is the enzyme inhibited by statins. And so by doing this, it lowers hepatic cholesterol synthesis and also increases clearance of LDL cholesterol from the circulation, just like statins. But what's intriguing about bempedoic acid is it's a prodrug. And it's activated by an enzyme that's primarily only in the liver, and it's not in peripheral tissue. So in theory, it's not activated in skeletal muscle, for example. This might reduce the potential for adverse effects on muscles, which we all know is incredibly important, as up to about 30% of patients, as we're all very familiar in our practices, are not able to tolerate statins because of muscle symptoms. And so, bempedoic acid in several studies have now been shown to reduce LDL by about 20% in several different populations. And this prompted the approval of bempedoic acid by the FDA way back in 2020 for secondary prevention, as well as heterozygous familial hypercholesterolemia. But uptake of and use of this medication really has been slow. And the reason for that is because we've all been waiting for a cardiovascular outcomes trial. And the game changed, as we all know, a couple months ago in March, when CLEAR Outcomes trial was announced. This looked at almost 14,000 patients that were intolerant to statins and randomized them to bempedoic acid or placebo and watched them for 3.5 years. And the trial overwhelmingly met its primary endpoint and reduced 4-point MACE. It met several of the key secondary endpoints, reducing MI, reducing rates of coronary revascularization. So what was presented at the ADA as this late-breaking poster was a pre-specified subgroup analysis looking at the effects of bempedoic acid on MACE, specifically in primary prevention population. About 30% of the original study were enrolled as primary prevention patients. It was about 4,200 patients. In general, these were 18 to 85-year-old patients with LDLs above 100. They had high ASCVD risk. More than 2/3 of them were enrolled because they had diabetes. That was the source of their cardiovascular risk. In general, these were patients that had a mean age of about 67. 59% of them were women. 66% of them had diabetes. Almost 20% of them were on a low dose of a statin. 8% of them were on Zetia. Randomized to bempedoic acid once daily or placebo and followed for a median of 40 months. And what they found is that bempedoic acid not only lowered LDL by the expected about 21%, but it met its primary endpoint. And bempedoic acid reduced 4-point MACE by 30%. That's a 2.3% absolute risk reduction. And a number needed to treat of 43 patients. They met several key secondary endpoints, including reducing MI by almost 40%, reducing cardiovascular death by 39%, reducing all-cause mortality by 27%. Of course, nothing is free. Folks who received bempedoic acid had higher rates of gout and cholelithiasis. They also had increased serum creatinine and elevated LFTs compared to placebo. But, consistent with kind of the central hypothesis of bempedoic acid, folks that got bempedoic acid had lower rates of myalgias and muscle symptoms than people who received placebo.
Thanks so much, Dr. Benson. It sounds really like an important poster. If you're going to summarize the main takeaway from the poster on a practice, on how it should change practice, or the main activation point for practice, what would that be?
I'd actually say there are 2 points. The first is we haven't had a trial in the last many years looking at the effect of lowering LDL in primary prevention. And that's because, it's been an answered question with the availability of statins. But what this study showed again was that lowering LDL cholesterol among primary prevention patients reduced cardiovascular outcomes. And so this supports guideline recommendations that patients with diabetes who you're treating for primary ASCVD prevention should definitely be treated with statins to lower LDL. Now, what the trial added to this, importantly, is that in patients who can't tolerate a statin, this really does nominate bempedoic acid, the use of bempedoic acid as a first-line therapy in those people who cannot tolerate a statin that you're treating for primary prevention. I would say it's still PCSK9 inhibitors if you're treating them with familial hypercholesterolemia or secondary prevention, but primary prevention, statin tolerance, bempedoic acid now has very good data.
Wow, that sounds great. Well, thank you so much. I'm going to keep pushing on, and I'm going to turn it over now to Dr. Bjornstad.
Thank you so much, Dr. Peterson. I'm also very grateful for the opportunity to be here. And the first session I want to highlight is improving outcomes for adolescents with type 2 diabetes. This was, in my opinion, a really brilliant session that was led by 3 talented speakers, including Katie O'Sullivan, Amy Shah, and Nita Vangipuram. All speakers really emphasized the urgent public health concern of youth onset type 2. As I'm sure many of you are aware, the incidence of youth onset type 2 is rising in parallel with the obesity epidemic. It's also a really aggressive phenotype of type 2 diabetes. We see worsening insulin resistance, faster rates of glycemic failure, earlier onset and also more rapidly progressing complications than what's been shown in adult onset type 2, as well as youth onset type 1 diabetes. The first speaker, Dr. Solomon, also emphasized some really important socioeconomic barriers that I think we need to be aware of, including that most of these patients tend to be from racial and ethnic underrepresented groups, and that actually 40% of these families have a gross annual income less than $25,000 and are on public health insurance. Dr. O'Sullivan also described a really neat interdisciplinary model that they have at University of Chicago, and also some quality improvement initiatives they've been doing, but also acknowledged the burden of doing quality improvement in a very busy clinical setting. Next, Dr. Amy Shaw really compared data between metabolic bariatric surgery in youth with type 2 versus standard medical care, and highlighted two large NIH-funded efforts, Teen Labs and Today, that implicated that metabolic bariatric surgery outperformed medical treatment at the time, but it's worth noting that that did not include the newer agents such as SGLT2 inhibitors and GLP-1 receptor agonists. Thankfully, Dr. Shaw is leading an effort now, also NIH-funded, called the STOMP trial, that will be including SGLT2 and GLP-1 receptor agonist for pediatric type 2 diabetes for a more fair comparison with weight loss surgery. And then finally, the last speaker, Dr. Vangapuram, really showcased a really neat community-based payer-led initiative where they were trying to prevent the onset of type 2 diabetes. And they called this initiative HEED, so help educate to eliminate diabetes. And it was really peer-led, focused on education of adolescents with really promising data. They were due to metabolic risk factors compared to control when they looked at 1-year follow-up data. So I think this holds a lot of promise for more broad application. Yeah, and that concludes my summary.
Wow, that sounds great too. That was a great session. If you were going to summarize the big main points, the activation points out of that session, what do you think those would be?
Yeah, great question. I mean, I think the most important thing or the take-home message for me for this session is the unique challenges associated with youth onset type 2. I think we need to recognize that this is not adult onset type 2. It's very different. It is associated with a more aggressive phenotype. They tend to have a lot of disease, and they may not respond similarly to adults to typical therapies. And it's also more aggressive in terms of complications. So we need to make sure we obviate any therapeutic inertia, which is very common when caring for pediatrics, and also be mindful of the underrepresented groups and some of the socioeconomic barriers when we care for these individuals.
Good points. Thank you very much. I'm going to turn it over to Dr. Taveira.
Hi. First, I want to say thank you to the ADA and the AHA for inviting me today to speak. It's truly an honor. And today, I really want to focus on the findings from 2 related phase 2 clinical trials evaluating a novel once-weekly GIP, GLP-1, and glucagon receptor antagonist called Retatrutide. This was presented during a late-breaking symposium at the scientific sessions, and they were published simultaneously in the New England Journal of Medicine and in the Lancet. The first phase 2 study evaluated 338 participants with obesity who did not, in fact, have type 2 diabetes. Participants were randomized to receive either 1, 4, 8, or 12 milligram doses of Retatrutide or placebo for a 48-week follow-up. After the 48 weeks of follow-up, the highest dose of Retatrutide led to an average reduction of about 24.2% in weight from baseline. The weight reduction threshold of greater than or equal to 5%, which is the clinically meaningful threshold of weight loss set by the FDA, was reached by 100% of participants who received either the 8 or 12 milligram dose of Retatrutide. At the 12 milligram dose of Retatrutide, 9 out of 10 participants lost 10% or more of their baseline body weight, and nearly half of the participants lost 25% or more. A quarter of the participants lost 30% or more of their body weight. And since there's significant heterogeneity in obesity, pre-specified subgroup analyses were conducted to evaluate predictors of response based on baseline BMI and sex. Participants with a BMI of 35 or greater had a greater mean percentage weight reduction with retatrutide than those with a BMI of less than 35 kilograms per meter squared. The mean weight reduction among participants with a BMI of 35 or greater was about 26% as compared to about 21.5% among participants with a BMI of less than 35. Women also experienced a greater mean weight reduction of about 20.5% as compared to men with a mean weight loss of about 22% with the highest dose of retatrutide. And the safety and tolerability of retatrutide was comparable to that, what we've seen with other incretin-based therapies for the treatment of type 2 diabetes or obesity. The most common adverse events in the retatrutide groups were gastrointestinal, and they were considered to be either mild or moderate in severity and were partially mitigated by using lower starting doses. This phase 2 study included a sub-study, which also sought to evaluate how to use retatrutide in patients with obesity and who also had non-alcoholic fatty liver disease or NAFLD. And they wanted to specifically evaluate the amount of fat in the liver and the changes over the follow-up period. The sub-study included 98 participants with obesity and non-alcoholic fatty liver disease who underwent MRI of their livers and also had biomarkers of liver injury and fibrosis measured in their blood. Findings showed that in those with non-alcoholic fatty liver disease, the amount of fat in the liver normalized in 9 out of 10 participants after 48 weeks of treatment with the 2 highest doses of retatrutide. These data indicate that retatrutide may have a potential to resolve non-alcoholic fatty liver disease. And this is important because currently 24% of Americans have NAFLD, and there's no currently approved FDA therapy for non-alcoholic fatty liver disease. And then finally, a second phase 2 study evaluated the impact of retatrutide on hemoglobin A1C, body weight, and in safety in those with type 2 diabetes over 36 weeks of follow-up. 281 participants were randomized to receive either 0.5, 4, 8, or 12 milligram doses of retatrutide or the GLP-1 agonist dulaglutide at 1.5 milligrams weekly or placebo. The findings showed that the participants with type 2 diabetes lowered their A1C by 1.3 to 2.0% after taking doses of 4 to 12 milligrams of retatrutide, compared to no change in placebo and a reduction of 1.4% in hemoglobin A1C with dulaglutide. Participants taking retatrutide also lost more weight than those who took placebo. The average weight reduction in the 12 milligram group was about 17% compared to 3% with placebo and 2% in the dulaglutide arm. Retatrutide, again, had an overall safety and tolerability profile similar to other incretin-based therapies approved for the treatment of type 2 diabetes. These weight loss are the most reported so far in a medication tested for the treatment of type 2 diabetes, and we're hopeful that these results will be confirmed in longer and larger randomized controlled trials. Thanks.
Wow, that's such important information, and there's so much there. Could you summarize again? What do you think if I was going to take away some information? What would be the takeaways? How should I change my practice?
So I think this might change the landscape and provide an additional option for patients with type 2 diabetes, because retatrutide shows clinically meaningful improvements in glycemic control, robust reductions in body weight, with a similar safety profile to other incretin receptor agonists that we're already familiar with, and may represent future treatment options for those with non-alcoholic fatty liver disease.
Perfect. Thanks so much. We're going to push on because there was a lot of sessions. There was a lot of information coming out. I'm going to turn it back over to Dr. Aroda. Okay,
so for the second session that I chose that I thought was really impactful was the Kelly West Award Lecture. And the award was presented to Professor Alka Kanaya at UC San Francisco for her work on understanding diabetes risk and cardiovascular risk in South Asians through the Masala study, mediators of atherosclerosis in persons in South Asians living in America. And this is a research program that she started 15 years ago, where she's just amassed a tremendous amount of data to help understand the underlying metabolic risk in South Asians. So I'll start first. The first big takeaway was not all Asians are created equally. You know, when we check the box, and I have to cringe every time I check the box too. You know, I'm not just Asian, I'm South Asian, and that has very different health implications. So they worked with the NHANES data set, where the prevalence of diabetes from 2011 to 2016 was 19% in Asians. But when they disaggregated that data, it turned out to be much higher in South Asians. It was 23% in South Asians compared to 14% in East Asians. So, you know, diabetes risk and prevalence is high in South Asians. In terms of understanding why, they compared their data in individuals without diabetes to those from people from the MESA study, multi-ethnic study of atherosclerosis, and found that South Asians uniquely have high insulin resistance, so high HOMA-IR, as well as low beta cell function as estimated by the HOMA-beta. So previously underappreciated that there's already low beta cell function. In addition, they did CT scans to look at ectopic fat, and there was high ectopic fat placement, or, you know, where fat was deposited in places where it shouldn't be, in the muscle, around the heart, and in visceral adiposity. So, and in the liver, also contributing to risk of diabetes. The other interesting finding was there's a lot, but when they subtyped the type of diabetes, they found that there's a high prevalence of diabetes manifested by severe hyperglycemia, so high A1C, high levels of insulin resistance, as well as low beta cell function. And this was also associated with increased coronary artery calcium score, so increased risk of cardiovascular disease. So the implication there is, you know, would you think about more of your organ protective cardiovascular risk reducing agents in this population? And then finally, a lot on interesting findings on lifestyle. You know, we tend to think of diet and lifestyle as generic, but here too, there were nuances. So there are many Indians who are vegetarian. Well, vegetarian doesn't necessarily mean healthy. So they subtype the type of diet, and, you know, a vegetarian diet in a traditional Indian sense or South Asian sense could be deep fried foods, high fat foods, high fat dairy foods, lots of sweets, as opposed to more of a Mediterranean style diet. And that had implications on metabolic risk as well. And then the last thing I'll say is, you know, they've started their next wave of recruitment into their cohort, recruiting people from Bangladesh and Pakistan. They found an exceedingly high prevalence of diabetes of about 46% in this next wave of immigrants, and expanding the cohort. So a lot to be done, a lot to recognize.
Oh, wow. More good information. That's really tremendous. A thing, again, I'm going to ask, if you're going to summarize just the main activation points, or some of the main takeaways, what would that be?
High prevalence of diabetes in South Asians, independent, and I didn't mention this, so thank you for jogging my memory, independent of BMI and independent of waist circumference. So you don't have to be overweight to be screened. So high prevalence of diabetes screen, and you know, think about more detailed lifestyle modification for these modifiable risk factors in this population.
Thanks so much. I'm going to keep pushing on, and let's go to Dr. Benson next.
Great. So for the second, you know, session that I wanted to highlight, I actually wanted to highlight a really incredible symposium on the 26th that with the title SGLT2 inhibitors and GLP-1 agonists in cardiovascular disease, an update for clinical practice in 2023. The session was chaired by Dr. Om Ganda from the Joslin Diabetes Center, and really had an incredible panel of you know, accomplished trialists, as well as thought leaders around SGLT2s and GLP-1s, including Dr. Darren McGuire from UT Southwestern, Dr. Carlos Santos Gallego from Mount Sinai, and Dr. Pam Taub from University of California, San Diego. And I would just say up front that the session was live streamed. So if I'd encourage you to watch it on demand as you're able to, because especially the discussion at the end with questions, et cetera, I found to be incredibly helpful. Just wanted to highlight a couple of takeaways that I got from the session. Of course, there's been dramatic growth, both in terms of data and experience around the use of SGLT2s and GLP-1s since, I guess, the fall of 2015 when EMPA-REG outcomes, was first available. And, what all the speakers, were able to clearly communicate is that SGLT2s and GLP-1s now clearly improve cardiovascular outcomes. Now, getting a little bit more in detail, there's a couple general observations that I think were emerging in terms of first the SGLT2s. In terms of just numbers, first there's been randomized controlled trials for 4 SGLT2s for cardiovascular outcomes trials: empagliflozin, canagliflozin, dapagliflozin, and ertugliflozin. And what's striking is that all 4 of those trials met their primary outcome of non-inferiority versus placebo for 3-point MACE, composite of cardiovascular death, MI, and stroke. When you meta-analyze across the 4 trials, the pooled benefit was 10%. But the important point that was made during the session is there's a lot of heterogeneity in that signal. And really, if you look, only 2 of the 4 SGLT2 inhibitors have achieved superiority, not just non-inferiority for 3-point MACE. And those 2 meds are empagliflozin and canagliflozin. Now, shifting, it's a totally different story for the role of SGLT2s in heart failure. Consistently, every drug tested, empagliflozin, canagliflozin, dapagliflozin, ertugliflozin, have been found to be superior to placebo in reducing rates of hospitalization for heart failure, with a pooled benefit of I hadn't seen this before, of 32%, which is really an astounding number. So shifting here, while SGLT2s have this really consistent signal for reducing hospitalization for heart failure, GLP-1 agonists, in the words of Dr. McGuire, are like statins. And they're really emerging as this idea that they're mitigating the risk of atherosclerosis. So far, in terms of numbers, there have been 8 trials of GLP-1 agonists. 6 have been statistically significant for the reduction of MACE, and 3 of these have led to product labels in the US for risk reduction of ASCVD in patients with type 2 diabetes, either with or a high risk of ASCVD. And those 3 drugs are liraglutide, dulaglutide, and semaglutide, the sub-Q semaglutide, with a pooled effect of 12% reduction in 3-point MACE. And I'll just kind of echo what Dr. Aroda already introduced. These have already made their ways into the 2023 ADA practice guidelines. And that document is exceptionally clear. I would encourage people to just take a look at that guideline. I'll just highlight 2 or 3 points from it. The first is that in this most recent iteration, the need for starting metformin up front before SGLT2s and GLP-1s has been removed. So, metformin is still a very efficacious med. It's also very affordable, but you don't necessarily have to start metformin before moving on to GLP-1s and SGLT2s. I'll just end by saying, the guidelines are now getting more and more clear in my opinion. If you have diabetes and you have ASCVD, it's really kind of a dealer's choice. You can use either a GLP-1 agonist or an SGLT2 that has a proven ASCVD benefit. And then if the A1C is still above target, it's very reasonable to add on whatever you didn't add on up front. If the patient has heart failure, you should start with an SGLT2 for sure. And if the patient has chronic kidney disease, if they have albuminuria, you should start with an SGLT2. If they don't have albuminuria, it's dealer's choice. You can start with SGLT2 or GLP-1. I guess I'll just end there. And I'll just say there's a lot in the pipeline So the sotagliflozin, which is a dual SGLT2/1/2 inhibitor, that was just approved for diabetes and heart failure last month. Cardiovascular outcomes trials around oral semaglutide will be available probably late next year, and cardiovascular outcome trials around tirzepatide, which is a GIP and GLP-1 agonist, will probably be available about the same time.
Wow, that's great. Again, all sorts of information. Again, I'm going to ask if you're going to summarize it. Just give me the main takeaways. How is it going to affect my practice? What's the activation points?
I think that at this point, there's so much high quality cardiovascular outcomes data that it's really crystallizing the guidelines that Dr. Aroda already outlined. And I would say it's worthwhile, printing those out and pinning them to the wall, because it's now becoming a little bit algorithmic, which is really a huge step forward, since EMPA-REG outcomes first came out 8 years ago.
Thank you so much. Let's push on. It was a big conference. Dr. Bjornstad, can you give us some additional information?
Yeah, thank you, Dr. Peterson. The second session I would like to highlight is beyond antihyperglycemic and antihypertensive agents for diabetic kidney disease. And I think this will actually amplify some of the important comments made by Dr. Benson. So I'm glad this is the sequence of order. This session was led by 3 excellent speakers, including Dr. Christine Lamonte from University of Washington, Dr. Sheesh Verma from Boston University, as well as Dr. Kaylee Tomerdal from University of Colorado. And in particular, Dr. Lamonte discussed whether we're actually following these new guidelines when it comes to SGLT2 inhibitors and GLP-1 receptor agonists, and summarize some really important data from her NHANES analysis. And from her NHANES analysis, she showed that actually 53% of adults with type 2 are eligible for SGLT2 inhibitors based on the guidelines, and 33% for GLP-1 receptor agonist. But despite these numbers, the actual use is much lower. It's actually, from her analysis, it was only 5.8% were prescribed an SGLT2 inhibitor between 2017 and 2020, and only 4.4% a GLP-1 receptor agonist. She also shared some insurance-based data from Optum that was slightly better, showing rates of 12% for SGLT2 inhibitors and 11% for GLP-1 receptor agonist. And she also showed some really discouraging data, including some racial and ethnic disparities in terms of SGLT2 and GLP-1 receptor prescription patterns, that they're prescribed less frequently for those that are of underrepresented race and ethnicities, also lower rates in women versus men, and also lower rates in those that are above 65 years of age. And she identified some potential barriers to this, including inaccurate diagnosis, difficulties with risk stratification, as well as access to care. But she ended on a positive note, highlighting the educational effort led by the American Society of Nephrology, the Diabetic Kidney Disease Collaborative, which is an educational effort targeted for primary care providers. And then the next session was by Dr. Verma. He really brought us to the future, saying that despite these agents working really well, they don't work well for everyone. And there's still some residual risk that we need to address. And he really focused on mitochondrial function as a unifying pathway that should be targeted, and discussed his experience in an ongoing trial at Boston University and Brigham and Women's Hospital, looking at NAD supplementation as a way to mitigate diabetic kidney disease progression versus placebo. This is a trial NIH funded in 140 adults with type 2, with the primary endpoint being improvement in UACR over 6 months. Data are still pending, but sounds very interesting. And then finally, Dr. Tomerdal brought it back to pediatrics. And she really illustrated the aggressive nature of pediatric type 2 by sharing a case from her clinic. And this was a 14-year-old boy that was on high doses of insulin, canagliflozin, tirzepatide, lisinopril, and atorvastatin. And despite having all these medications administered with parental supervision, did not reach good glycemic or metabolic control. I think it really illustrates the aggressive nature of this disease. And then she also shared with us the slow path of FDA approval for these drugs in pediatrics, which is why they're often used off-label. She reminded us that metformin was actually approved in 2000, and it took 19 years for the next drug to be approved for pediatrics, liraglutide. But thankfully, June 20th, now we also have empagliflozin approved. But it really showcases that we need to do better in terms of the approval path for pediatric type 2 diabetes. And that concludes my summary of this session.
Well, thank you very much again, Dr. Bjornstad. Really important information. If again, I'm going to ask you just to give me some highlights, the main activation points.
Yeah, no, thank you. I think the main takeaway for me for this great session is that we really need to advocate for increased use of these newer agents, SGLT2 inhibitors and GLP-1 receptor agonists, really also focusing on underserved groups, as well as women and those above 65, just based on the data, and now also pediatric type 2, since it's on label.
Thank you so much. It's great stuff. Boy, this is a great conference. It was clearly a great conference. Dr. Taveira, I'm going to move to you.
Yeah, so one session that I was extremely excited about for great things to come was the session that highlighted the results of the OASIS 1 and Pioneer Plus study. The OASIS 1 trial aimed to evaluate a new formulation and a higher investigational dose of 50 milligrams daily of oral semaglutide versus placebo for weight loss in 660 individuals who were overweight or obese but did not have type 2 diabetes. The co-primary outcome was the relative change in body weight and the percent of patients who again lost that 5% of their body weight threshold from baseline to week 68. The estimated mean body weight change from baseline to week 68 was a reduction of about 15% with oral semaglutide 50 milligrams versus 2.4% with placebo. This change in weight loss is comparable to what was achieved in the STEP 1 trial with the injectable form of semaglutide 2.4 milligrams injected weekly. 85% of those who received oral semaglutide versus only 26% who received placebo achieved that 5% threshold reduction in body weight at 68 weeks. And 69% of those randomized to receive oral semaglutide versus only 12% who received placebo achieved a 10% reduction in body weight. And more than half of those who received oral semaglutide versus 6% of placebo achieved a 15% reduction in body weight. And again, the adverse effects that were experienced by those were mild to moderate and gastrointestinal in nature. And they, of course, were more frequent with oral semaglutide, which was about 92% of those in the semaglutide arm, but 86% in those in the placebo. In the second trial, the Pioneer Plus study compared the current maximum approved dose of 14 milligrams daily of oral semaglutide versus 25 or 50 milligrams daily of oral semaglutide versus placebo in a little over 1,600 individuals with type 2 diabetes. The primary outcome measure included the change in A1C from baseline to week 52. And there was also a second confirmatory outcome, which was the change in body weight over that 1 year of follow-up. Participants who were randomized to the 50 milligram dose of oral semaglutide achieved a 2% absolute reduction in A1C and lost 10% of their body weights. These results are comparable to what we saw in the STEP 2 study with injectable semaglutide in terms of A1C and weight reduction. Very exciting results.
Yeah, that sounds really impactful. Again, I'm going to have you just kind of summarize the major takeaways.
So I think the major takeaway is that this represents a major medical advancement in that it introduces an oral option to improve both glycemic control and weight loss in type 2 diabetes. And that the fact that oral medications are relatively easy to administer, and it's exciting that, as of right now, it seems to appear to have the same magnitude of efficacy and tolerability as the injectable forms of GLP-1.
Well, with that, we're going to wind up we're going to end the panel discussion. Thank you so much, Dr. Taveira, and thanks so much for all of our panel presenters for a really great discussion. Now, if you haven't done so already, please ask your questions for today's panelists by typing them in the Q&A box. The slide here contains a list of the sessions that were discussed by each speaker today. As we begin to gather some of those questions, and as they come in, I'd like to remind you to check out the nodiabetesbyheart.org, where you can find the latest guidelines, including the 2023 standards of care from the ADA, as well as patient educational resources and other interactive case studies that are available. With that, I'm going to open it up for questions. Maybe I'll just kick it off to begin as people enter their questions. What are the implications of these changes on team-based care? We have team-based care is an important way to deliver some of this care. Are these going to affect the way our team works?
I'll go ahead and start. And I also see that there's a lot of questions in the chat regarding costs. So I think we should get to that one too. But what it speaks to me is that we actually have a lot of tools. And I think we're not using all the tool users. So, we really need to start thinking about the extenders of the single physician, where there can be medication managers to quickly intensify approaches there and walk people through potential side effects and really reinforce the goal. So I think, and again, if you look at the standards of care, there's a real spotlight on the emergence and role of community health workers and the extended team.
I would just like to echo that too. I thought this session, there were a couple sessions and several talks as well as posters that was highlighting exactly that issue. And I think, there was a fantastic session that delivered both by endocrinologists as well as pharmacists and cardiologists, outlining very large efforts to improve this, things like starting, improving training around cardiometabolic fellowships, around population-based systems using pharmacist-led programs, very large, changes that I think are in the pipeline and may take some time to come. I think I'll just highlight one quick change that, one speaker said, when she's asked, well, who should start an SGLT2 or a GLP-1, her answer is now the first clinician who sees the patient. Doesn't matter if you're an endocrinologist, it doesn't matter if you're a PCP, it doesn't matter if you're a cardiologist. First person to see the patient should put them on these drugs.
These are going to be really big changes in some of our practices as we go forward. You mentioned an important question already, Dr. Aroda, and I see that it has come up now here in the from our watchers, our viewers. Isn't the cost going to be a major problem here? And how are we going to get around that? How do we get these drugs to the public?
I think that's the elephant in the room. And so it's important that we talk about it and acknowledge it. I'll share with you from the guideline perspective, we talked about it. And if we look at the evidence from the cardiovascular outcomes trials, in order to demonstrate benefit, they're done in higher risk populations. And so the youngest age was age 55 and older with cardiovascular risk. And when you look at the stratified analyses, the higher absolute risk reduction was seen in those who had higher baseline risk. And so will we see those same risk reductions at the lower risk? Probably not, and probably not for years to come, because we're not preventing heart disease within 5 years in a 40-year-old individual. And so that plays into the societal dilemma of we have the high cost and the risk and absolute risk reduction changes over time. And then conceptually, if it was you or if it was your family member, knowing what how would you want them treated? And yet guidelines, what they recommend, you need to think about whether they're implementable around the world.
Yeah, it's a big change going from efficacy to effectiveness and to move that to disseminate this information. I'm going to push on with another question here, and that was, when is it safe to start an SGLT2? I mean, in view of euglycemic hypoglycemia, is there a time when it might not be safe, or when would you think about it?
So I can take a stab at that, and then I would love to get others involved too. But when I really don't consider it safe, and I know this may be not controversial, but other people believe it may be safe, is in type 1 diabetes, right? Because there the risk is for euglycemic DKA is much higher. There are a few circumstances where this could be mitigated. So if you have an individual with type 1 that have more severe chronic kidney disease, we know that their risk of euglycemic DKA is somewhat attenuated. So if you have more advanced kidney disease, the risk of euglycemic DKA is somewhat attenuated. I saw the question in the chat with an individual with an A1C above 10%. This was an individual with type 2, I believe. I would not be so concerned about euglycemic DKA in this case that I would not prescribe an SGLT2. I still think an SGLT2 would be worth the risk, but I would love to get other panelists' input.
I also think, again, think about your person-centered goals. For the person whose A1C is above 10%, an SGLT2 inhibitor is likely not going to get them to goal. So think about your GLP-1 receptor agonists, your insulin, and then because they have heart failure, think about the SGLT2 inhibitor for mitigating heart failure progression and risk.
One of the big changes that we've seen, especially since COVID, is the increased use of telehealth. It can be particularly valuable in underserved areas or in rural areas. What do you think what are the impacts on telehealth here, or is telehealth going to impact this treatment? Is there a role for telehealth in these meds?
Yeah, I think, I think as we were kind of alluding to, in the prior question, in a sense, it's kind of it's nice that we're in this situation where the problem is not having tools. The problem has now shifted, at least in large part, to delivery. And so I think there's an immense amount of research around how do you deliver these drugs in a fair and equitable way. And telehealth, I think, has, partly because of the pandemic, has given us another option that is, I think, under a lot of study. There were several presentations that were highlighting pharmacist-led programs that were heavily reliant on telehealth in terms of initiating and monitoring meds that have cardiovascular benefit.
Yeah, I would second that, because as we see that these drugs require a long period, somewhat long period of titration, right? Going up each week, assessing, maybe down titrating other medications that could put the patients at risk for hypoglycemia. And there's some tolerability issues that can become overcome, right, with counseling and addressing them. And there was data presented at the SCI sessions that showed that there was a problem with persistence in some of these medications. And it was not entirely clear if it was truly due to cost or tolerability over time. And so having this option of frequent touches, reaching out, figuring out if patients are continuing these medications, and then addressing barriers or addressing adverse events could help with persistence and up titration.
Are the GLP-1s effective when they're used along with insulin?
There's plenty of phase 3 clinical trial data showing their effectiveness as add-on to insulin therapy. And a lot of times what you'll see is you can reduce the dose of insulin because they have an insulin-sparing effect.
So with a lot of these new drugs, and we've seen a substantial impact on weight. How is this going to affect practice? I mean, with weight gain being, are we going to be targeting weight gain here? Are we targeting diabetes? Is diabetes, how integral is weight to diabetes nowadays? I thought it was a glucose-centric disease.
And I think Dr. Aroda and her team did a great job in kind of shifting the focus of the guidelines and saying that it shouldn't necessarily be diabetes-centric, it should be whole-centric, right? And focus on glucose as well as weight management. And I think having these new novel mechanisms coming to the market, it may perhaps make it more equitable. And so that way we have more options, especially with oral formulations, to address this, and maybe even rethink the obesity paradigm of, is 5% enough now that we can achieve 16, 20%? Maybe that's where we should be setting the mark for, or the target for therapy.
I'll share the concept that weight management can impact glycemia isn't a new one. It's been studied for decades. And I think it really challenges the notion that diabetes has to be a naturally progressive disease where you just keep adding medications and that's just the doomsday course. It's not. I think what we're seeing is that there are ways to regress and in some cases remit disease when you think about weight management.
I think another kind of takeaway that I walked away from this sessions with was a point made by one of the speakers that, if the goal is to reduce the risk of cardiovascular disease or other kind of, complications downstream, each of these meds excitingly is targeting different biology. And so it makes sense that you can use these in combination that they're additive, and just like you wouldn't hesitate to put somebody on aspirin and a statin because they're targeting totally different pathobiology, it makes sense that all of these new meds, GLP-1s and SGLT2s, et cetera, are targeting different pathways and different sources of risk.
And one additional piece of information is in both the study with oral semaglutide and retatrutide, even though in the obesity studies, they didn't allow patients with type 2 diabetes, they allowed people with pre-diabetes, they had regression of their disease as much as 72%.
So we are out of time. I think that there were some really great questions here. We could continue on. I want to thank everybody, all of our speakers, and I want to thank all of our participants for the work and covering what is really an exciting, what was an exciting scientific sessions. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.